Testing 1 2. Testing 1 2. Testing 1 2.
You didn't change it from the original one.
No, I have not changed any of that. I was kind of wanting to see if there was a way that I can get that.
ahead and just talk a little bit like you're talking to them.
Testing. 1, 2, 3, 4. 1, 2,
Take
3, 4.
about 5 seconds so I can hear it.
Okay. Well, I'll just pretend that I'm having a conversation with you then. I'm assuming that's about how far I need to project my voice. Now, I can project it all the way to Lisa if you want me to.
Hang on 1 second. Okay, go ahead now.
It's a good time to see you here. How are you doing back there? Everyone back in the back that decided that they don't want to sit in the front so they won't hear me.
Back right back.
That's as loud as I'm going to get.
Yeah, you're fine on this.
Okay, cool. I just got notification that I'm live on the audio as well as the video. For those of you who are visiting us through live stream, I'd like to say welcome. I'm currently waiting for the audience that are here to get settled in so we can go ahead and begin. It'll be a few minutes.
Don't forget your handout when you come back to her.
Going to do the same thing in September?
My intention is to progress from this point forward for any further CEUs. The current Ascension recommendations is to get to the Niosh list and have the Niosh list created and then start making plans for using it and implementing it there. The question was, am I planning on continuing to do this into September? My plan is actually to work from here and move forward with the criteria that are necessary to be met in order for us to be USP Chapter 800 compliant by its live date of December 1st of 2019.
There you go. I'm sorry. I did that on purpose.
Okay. Yes, ma'am. I'm gonna be on my best behavior.
It says she's gonna behave. Once these guys get up here and sit down, then we'll get started.
Okay.
My first question is, what's the answer to
I'm actually going to go over that at the end, so
Okay.
yeah.
So I guess I'll understand.
Your son still out in Texas?
Here,
He's in Victoria, right?
yeah. They gonna take, see, I wanted to go visit him in June,
Yeah.
but he was gonna come home in June. So I said, well, since he coming home,
Why don't fall, maybe?
I said, well, maybe since this year I'm off Monday, well, Christmas on I think a Tuesday.
Yeah, so you're gonna go to Christmas.
So maybe we can go after Christmas and spend Christmas. Cause it's off days, like Monday and Tuesday.
Has your daughter finished up yet? Or she's still on?
Um,
Down at,
She graduated this month.
No. My time flew. No way.
It did.
She, what's her future plans? Is she going to medical school or something?
Yeah.
I'm sitting on the end of it. No,
She should
not
be
me.
trying to get
I don't know
it
who's in it.
Terrible. Good.
Gotta get after your secretary, so go ahead.
I've been told that I needed to begin. I'd like to say welcome. Welcome also to our members that are here via live stream. I'd like to welcome you guys. I consider it a privilege to speak before you guys. Concerning USP Chapter 800, it's a primer for pharmacies and healthcare settings. I hope this information serves you well in order for us all to get up to par and at least have an increased awareness as to what USP 800 is, what the requirements are, and how we need to change some of our processes in the pharmacy setting in order to meet those guidelines that are coming down the pipeline and have an active date of December 1st of 2019. I'm Brad Nix. I'm a clinical staff pharmacist at St. Vincent's East in Birmingham, Alabama. I've been a pharmacist since 2002. I've been in the pharmacy business as a technician, student, or pharmacist for about 30 years now. I started off in the United States Navy as a technician. And as my career has progressed, I've realized that a lot of the requirements that come down through the federal government and through federal regulatory agencies and state regulatory agencies, sometimes they'll get kind of confusing, but they always require some sort of change. So as a reflection, I like to start off by saying that everybody has some chance or some opportunity to change and improve, but not everybody takes that advantage. We need to be the type of people that do take advantage of the ability to change and progress. This quote is actually from Nick Saban. We are in Alabama, and I am a huge Alabama fan, especially to Nick Saban. And if anybody wants to read that book, it's really a good read. I have no disclosures, no relevant financial or non-financial disclosures to make. I'm not getting paid to do this. This is something that I've picked up on, and I have a certain level of passion about getting this done right and progressing not only my hospital but other hospitals in the Ascension family forward with meeting the requirements necessary to be compliant with USP 800. As course objectives, we're going to talk about the history and of USP 800, what it is, where it comes from, what it's requiring us to do. And then we need to think about creating a hazardous drug list based on the Niosh criteria. We'll talk about Niosh early too. Then we're going to discuss the requirements of USP Chapter 800, but only in terms of containment for right now. USP 800 is such a huge topic that we can't really do all this in just one presentation. So we're going to talk about terms of containment because it's directly related to the Niosh list. We're going to talk also about some of the standards that we need to be thinking forward. We have that forward thinking process of possibly implementing standards of practice in order to meet some of the other Chapter 800 requirements that are actually going to be presented later on this year. So let's talk a little bit about USP 800 and what it is. First of all, it is a federal document. The USP comes from the United States Pharmacopoeia Committee. It is a federal document that provides standards and guidelines on how to do certain things. We're familiar with 795, we're familiar with 797, which deals with non-sterile and sterile compounding requirements and protocols. USP Chapter 800, if you want to make it as simple as possible, it deals with reducing the exposure to hazardous materials. That's all it does is it addresses how we should handle hazardous materials in order to reduce the exposure that we have on a day-to-day basis. It's also got FDA involvement. The Food and Drug Administration is part of this because we deal with drugs. The CDC is involved with this, including the Niosh. Niosh is the National Institute of Occupational Safety Hazards. What Niosh used to be was with OSHA, and it has taken the same ideas of containing and reducing levels of exposure to hazardous chemicals, and now we're kind of pushing that into the medical world. So now Niosh has actually been branched with the CDC as well as having some OSHA involvement. So we're talking about some of the prior practice guidelines and how it's affected public health. Anyone who's familiar with the first implementation of 797 as far as sterile products is concerned, they had a chapter in 797 that dealt with how to handle hazardous drugs, and that was basically brought about by not only USP but also ASHP as far as how to handle these drugs, and it really wasn't its own entity until USP 800 came about. But Niosh, as an extension of OSHA, because it was dealing with hazardous materials, the federal government got word or recognition of certain events that have happened as early as, say, 1973 or 1974, in which people were documenting exposures, prolonged exposures to certain hazardous drugs, and then having deleterious effects such as, early leukemias or certain types of cancers. So we've got the documents all the way dating all the way into 1974. So the reaction has been slow as far as being able to address how to handle these materials. But ASHP got involved, and they came up with their own guidelines as far as how to handle these things as far as the hazardous drugs are concerned, in order to reduce those risks that are associated to those particular type of drugs. The Oncology Nursing Society has also been involved in that, and they've got their documented evidence of nurses themselves being the administrators of what we used to call chemotherapy. That's really not the way I would address it anymore. But whenever they were administering the chemotherapy, they were being exposed to these agents for prolonged periods of time, and then there's documented evidence that this has been causing healthcare issues with the administrators of the drugs and the handlers of those drugs. So the scope of USP 800 is now any occupational exposure to a hazardous drug. So this is not just a pharmacy issue. This is a pharmacy issue and a nursing issue, an environmental services issue, a transport issue. Anybody who handles these drugs needs to understand that they have the ability to cause deleterious effects to you. And that's what the USP 800 has come into play with, as far as creating these standards and these guidelines that gets us up to par and up to speed, and as far as recognizing these entities, these drugs, and being able to come up with techniques and standards of practice in order to contain these drugs. So we've got the federally established standards, which is USP 800, that deal with all healthcare personnel, and the intent is to strictly reduce exposure to them. So now we're talking about compliance with USP 800. USP 800 has been written, it has been reviewed, and it is actually up for publication and actually enforceable December 1st of 2019. That date used to be July 31st or July 1st of 2018, which is this year, but they've pushed that date for two reasons. Number one is because the USP has recognized that not everybody has been able to make the adjustments that they need to do in order to meet the requirements for USP 800, but also because there are expected changes to USP 797 that kind of pair up with USP 800 that also become effective on December 1st of 2019. So the current status of Chapter 800 is it's available, it's out there. You can get it off the internet, especially under the USP website. You can get it in a PDF format to read the document itself and make your choices and decisions as far as an entity is concerned, in order to see what's going to be required of us come December 1st of next year. Which is the expected official date. The expected official date is next year, and it's also the enforceable date. So we've got other organizations that have the ability to survey the hospitals, like Joint Commission, the State Board of Pharmacy, the State Board of Nursing. Those type of regulatory organizations also know what the requirements to USP 800 are going to be, so they're coming up with their own standards and their own med management protocols in order to meet those guidelines, and then they can hold us accountable to those. So the first thing that we need to do as an entity is to talk about what's called a Niosh hazardous drug list. Okay, Niosh again is the organization that used to be part of OSHA and is now part of the CDC, that has come up with certain levels of or certain criteria that are helpful in defining what a hazardous drug is. And I think that that's a very important part of being able to create your list and also to create the standards of practice that we're going to have in order to contain these drugs, is to identify these drugs and to categorize these drugs into how hazardous is hazardous. So we're going to define hazardous drugs according to Niosh. We're also going to maintain a hazardous, these are all OSHA requirements that we have to define what a hazardous drug is. We're going to use the Niosh criteria to do so. Maintaining the hazardous drug list is something that's responsible for the pharmacy to do, but it's not strictly a pharmacy function. Whenever we create the hazardous drug list, especially when we start talking about containment for the hazardous drugs, we need to think that that's the entire entity itself, the entire facility itself. We need to think outside of pharmacy and start thinking about other departments like nursing, like environmental services, like transporters. So then we talk about the USP 800 containment strategies. Basically, all we're talking about is how do we prevent or reduce levels of exposure to these entities that we've defined as hazardous drugs. We're also going to discuss what an assessment of risk is. This is a big key issue with what USP 800 has available right now, is how do we meet the requirements of containment using this tool that's provided in the document itself, talking about assessments of risk and what they are and how to use them. So let's define a hazardous drug. Niosh defines a hazardous drug as any drug that includes or exhibits one characteristic or more characteristic in either animals or humans. So in all of these drug tests that they do, if the drug is carcinogenic, it's hazardous. If it causes organ damage, it's hazardous. If it causes reproductive toxicity, it's hazardous. If it causes teratogenicity, it's hazardous. If it causes genotoxicity, it's hazardous. And then any structure that we don't know how it works or what it does, but if there's any structure of a new drug that mimics anything that's currently on the list, you need to consider it hazardous until we get information otherwise. So one of the 6 characteristics, Niosh has done extensive research on the list that it currently has. The Niosh list itself is produced every 2 years. They've got one now for 2018, but they haven't published it yet. So whenever they do publish the 2018, that'll be our latest edition of the Niosh list, and that should be a tool that we can use. Niosh categorizes hazardous drugs into 3 different categories, group 1, 2, and 3. Group 1 is the most hazardous of hazardous, and group 3 is the least hazardous of hazardous. Group 1, these are your chemos. Okay, and I really don't like saying that phrase because now we're not talking strictly about chemotherapy because we've got these other groups of characterized drugs that are considered hazardous. So we can't just say our chemotherapy protocol or our chemotherapy standards of operation. We need to start considering it hazardous drug standards of operations. But group 1 is your antineoplastic drugs. Group 1 also includes those entities that you don't know how they work, but they have some sort of structure that's similar to a chemo drug. Or if you don't know how they work, period, you need to make sure that they're considered Group 1 and treat them like they're antineoplastic until you find out that they're not hazardous. This is for any new entity that comes onto the market that we don't have enough information on. And this also includes any type of research drug that we don't know what it does. Okay? My recommendation is that you call those group 1 drugs and not antineoplastic drugs. I mean, although for the predominant part, 99.9% of all Niosh group 1 drugs are in AHFS classification 10, which means that they're antineoplastic. There is one particular one that is vaccines, for instance. The BCG vaccine is considered a group 1 drug, but it's not an antineoplastic. It's a vaccine. My suggestion to anybody who wants to come up with a program or a standard of operation or practice that talks about these drugs, that you don't label these as antineoplastic drugs for something I'll talk about later on. Group 2, it talks about non-antineoplastic drugs. These are the drugs that cause the organ damage and the teratogenicity and all that kind of stuff, but they're relatively dangerous. Some of the Group 2 drugs may include some of the hormones that are out there, some steroid products that are out there may be considered Group 2, but these are the drugs that that cause certain type of organ damage, cause certain type of teratogenicity, and can also cause reproductive risk. And then group 3 are those drugs primarily pose a reproductive risk problem. Okay, so this is one of those drugs that if you touch it, or if you ingest it, or if you absorb it somehow, it could basically sterilize you and eliminate your ability to have children. So the reproductive risk category specifically talks about those people, men and women, who plan on having kids. So we're talking about the hazardous drug list and how we need to maintain it. This is from USP 800. It says that we need to maintain the list of hazardous drugs, and we need to include the drugs that are on the Niosh list, but we also need to include other agents that aren't necessarily on the Niosh list. This might include monoclonal antibodies, certain antiretrovirals, certain other drugs that we consider to be considered hazardous, but aren't necessarily on the Niosh list. And when I say that, I can also say that it's probably not on the Niosh list yet. If we do the research behind a drug and we deem that it has certain characteristics that would include it on our Niosh list, more than likely it'll appear on the Niosh list, the actual national Niosh list. Okay, so the Niosh list of antineoplastic and other drugs provides the criteria used to identify the HDs, the hazardous drugs in our facility. So we need to identify the drugs that are in our facility. We cannot use the Niosh list as our list of drugs that are in the facility, because the Niosh list is all inclusive and we don't carry everything that's on the list. Okay, but we do need to make sure that we use the same criteria to identify those drugs that are going to be on our list. Okay, the criteria used to identify the hazardous drugs or enter the market after the Niosh list, we need to make sure that we have a process in our facilities that goes through P&T of we get a new entity, we're considering adding it to our formulary, or we're considering carrying it, or we're considering dispensing it. It needs to run through a process of acceptability to the formulary or deniability to the formulary that includes the criteria that identifies it as hazardous or not. So that needs to be part of our process of adding and subtracting drugs to our facilities. If the information available on a drug is not sufficient enough to make an informed decision, we need to consider it hazardous. So if we consider it hazardous, and because we don't know what it does, we need to really consider that a group 1 hazardous and not a group 3 or group 2. Okay, because the containment levels of containment change depending on how hazardous it is. So we'll talk about containment strategies. Any anti-neoplastic hazardous drug, your group 1 guys, okay, that requires manipulation. If it's a tablet capsule that we open, crush, split, change the dosing formulation one way or the other, if it's a liquid that we have to pour in order to get the dose and we remove it from the original container, that's manipulation. And obviously, if it's an injectable form that we have to make IVs out of, IM injections, sub-Q injections, anything that we have to draw up in a syringe for the nurses, that is manipulation. So any hazardous drug requiring manipulation and any hazardous drug pharmaceutical ingredient, active pharmaceutical ingredient on the Niosh list has to follow the containment requirements that are in USP 800. These are the guys that you would expect to have a separate storage area, negative pressured. You're trying the utmost of containment has to be done on these antineoplastic drugs that require manipulation. And the important thing in this particular verse is the active pharmaceutical ingredients. Here's an active pharmaceutical ingredient. If it is on the hazardous drug list as an entity in group 2 or 3, okay, we'll pick on group 3 for instance. Let's say that the drug is medroxyprogesterone. It's Premarin. Okay, a conjugated estrogen. Let's say it's Premarin. Okay, you've got Premarin in 3 different dosage forms. You've got tablets, you've got creams, and you've got injectables. Okay, the injectable is a hazardous drug, but it's not an antineoplastic. Okay, so it's not really considered group 1, even if you have to draw those injections up. It's considered a hazardous drug, but it's not considered a group 1 hazardous drug. But that Premarin cream, if you remove the Premarin cream from its tube to create another entity, another cream, a mix, for instance, if you compound with it, it's considered an active pharmaceutical ingredient of a hazardous drug. Regardless of its classification, it is now considered a Group 1 and has to be stored in negative pressure and has to be compounded in negative pressure in a hood using the 795 guidelines. Okay, so that's just to let you know that just simply taking this stuff out of the tube and doing what you're doing with it increases its level of risk of exposure. All right, any final antineoplastic dosage form. Now this is important. Any final dosage form that doesn't require any further manipulation other than counting may be dispensed without any further requirements for containment unless required by the manufacturer. So if you've got an antineoplastic drug that is a unit dose tablet and you know that it's going to make it all the way to the patient as that unit dose tablet, it does not have to be stored like your injectable chemos. Okay? Here's an important thing though. If it's a liquid, such as Majestrol, that has to be in its final dosage form. It has to be produced by the manufacturer as its final dosage form. If it's a 10 ml dosage form, it has to be manufactured that way in order for it to fall under its final dosage form. If you have to pour it, that's manipulation. And it has to be treated like a Group 1, negative pressure, 795s and negative pressure hood. Personal protection equipment. Okay? That type of thing has to happen. But if it's in its final dosage form, this allows you to dispense it without any further requirements for containment unless it's suggested by the manufacturer. So now we're talking about non-antineoplastics and non-active pharmaceutical ingredients. Let's just say that those two are the group that has to follow every strict guideline set into play by USP 800. We're talking about the other ones that don't meet that. They're not antineoplastic, they're not Group 1. Okay? What about Group 2 and Group 3? We have a choice. We can either treat Group 1 or 2 and 3 as Group 1 and put them under the same levels of a containment as everything else as far as your chemo is concerned, that chemo mentality. We can treat them all like chemo, or we can list those drugs by dosage form, do a risk assessment on them as far as how much of a level of exposure do I have whenever I manipulate them, when I transport them, when I store them, when I receive them. How much is my level of exposure increasing or decreasing depending on what I'm doing, what kind of a drug is it, what kind of harm can it possibly cause, and then we do a containment strategy analysis of that and make that part of our assessment of risk, and we can store those according to alternative containment strategies other than what USP 800 has said. But we have to have those assessment of risks on every drug and every drug form. So let's go back to Premarin. If we want to store Premarin, however we want to store Premarin and how we deem it's necessary to store it in order to have adequate containment strategies to it, we have to have a Premarin injection form, we have to have a Premarin cream form, and we have to have a Premarin tablet form. Okay? It's every drug and every form has to have its assessment of risk. Okay? Talking about assessment of risk. The requirements from USP 800 says the assessment of risk has to identify the type of hazardous drug, Group 1, 2, or 3, risk of exposure, what is it that you're doing to it that's going to cause it to be absorbed into your body more readily, how we're packaging it, is it something that we're putting in unit dosing, is it something we're drawing up in a syringe, is it something that can leak, is it something that is contained, is it a closed system, how we manipulate it, are we crushing it, are we opening up capsules? Are we pouring the liquid? Are we just counting the tablets that are considered powdery? Are we injecting liquid into or water into a lyophilized vial? Are we doing that kind of thing in order to even to make an oral dose? What is it that we're doing to that drug and that dosage form that's going to increase our level of exposure or absorption? And then we need to talk about the alternative containment strategies. How do we store these things? Do we put them in with regular drugs? Do we have to set them aside somewhere in a segregated containment area? Do we put them in negative pressure? Do we meet all the guidelines associated with Group 1 and consider them the most hazardous of the most hazardous? Are they considered active pharmaceutical ingredients now that we're doing stuff to them? That type of thing needs to happen and needs to be part of the process of making sure that your containment strategies are adequate enough to meet the assessment of risk for your facility. This particular slide's a little bit busy. This was something that I personally worked on since I was assigned the USP 800 criteria. My first reaction was to recreate the 2016 Niosh list in an Excel format. Okay, so I've got the entire 2016 Niosh list in Excel and not PDF. So now I can cut and paste, I can put in different columns, I can put in different criteria that I need to have in order to meet not only the Niosh criteria for identifying the drugs, but also I can extrapolate this information and use it to create my assessments of risk. Okay. Again, this particular document identifies group 1, 2, and 3 based on how Niosh identifies them. And if you'll notice, that last column to your right is the Niosh group 1, 2, and 3. Okay? I do not call them antineoplastic, non-antineoplastic, and reproductive risk only. Okay? Because if there's a situation in which I need to dispense a dose of a non-antineoplastic group 1 drug, and I send that drug to the unit for the nurse to give, and it's labeled antineoplastic, the nurse has the potential to say, here's your chemo, and it's not chemo at all. Okay, so that, in my opinion, really isn't adequate patient care. We're going to talk a little bit about different ways to do the assessment of risk. This particular assessment of risk was done by the University of Kentucky in 2014. And this is a situation where they take all of the criteria that's required from USP 800 and they put it on one page. So essentially you'll have a big notebook of an entity, a dosage form per page. Okay? It can be done that way. It doesn't have to be done that way. They can actually, your assessments of risk can actually be spreadsheets. Okay? Which brings me to this. Remember my Niosh list that I had on Excel. That's the blue portion of this particular slide here, is my Niosh list. I can literally cut and paste the drug per line and put it where I want to on this assessment of risk document. And then the first thing that I do is say what kind of dosage form it is, and then I start talking about splash potentials, containment strategies, manipulation protocols, what's going to escalate my exposures, that type of thing. And I'll have it all in one big formed spreadsheet where not only can this spreadsheet be used as a tool, but it can also be sent to the nursing unit. It can be sent to environmental services. They can have this and they can use this tool themselves and be able to alphabetically find a drug, determine what Niosh group it is, and determine some alternate containment strategies for it. Okay, which brings me to this slide. This slide I worked on again back in May or June of last year. I had it completed by September of last year with the hopes that actually the expectation that USP 800 would become enforceable in July of this year. So this particular slide breaks it down into group 1, group 2, and group 3 drugs. And then once you determine whether it's a group 1, 2, or 3 drug, anywhere in the facility with that previous document that I had, which was my assessments of risk, you can determine whether it's a group 1 drug, work your way down the algorithm of whether it's an intact tablet, whether it's a tablet or capsule that looks like it's powdery, may form some residue, whether it's a topical preparation, whether it's an injectable, irrigation solution, that type of thing, and then work your way down that particular cascade down that page to determine what kind of protective equipment you're going to need to have on when you're doing whatever function you're doing with that particular drug, whether you're receiving the drug, whether you're dispensing the drug, whether you're compounding the drug, whether you're wasting the drug, whether you're cleaning up the drug as far as a spill is concerned. Okay? This is group 2 and 3. The previous page was group 1. This is group 2 and 3. Okay? So the personal protection equipment as far as the containment strategy is concerned changes depending on what the drug is and how the drug works as far as how it's considered hazardous or not. So literally you can take the previous documents, determine what group it is based on Niosh, and then based on that group follow the cascade to determine what kind of protective equipment you're going to have to wear. And this particular document works throughout the entire facility and not just pharmacy. So let's talk about USP Chapter 800 requirements in terms of containment. We need to figure out what a level of exposure is to begin with. So we talk about levels of exposure. We're going to talk about engineering controls. We're going to talk about barrier controls. All right? A level of exposure is determined based on two things. The characteristic of the drug itself. Group 1, Group 2, and Group 3 are all categorized based on the characteristic that the drug has. Okay? Something about a Group 1 drug makes it more hazardous than a Group 3 drug. Okay? Something about that chemical itself, whether you ingest it or whether you absorb it, however you absorb it, is going to cause more harm than if it was a Group 3. So the characteristic of the drug itself is chemical. Okay? How it's going to be exposed. The exposure escalates. Your risk of exposure escalates depending on what you do with that particular product. Okay? For instance, if all I'm doing is receiving the drug and it's intact and in a plastic bag and I'm taking that drug and placing it on the appropriate shelving, my level of exposure isn't as dramatic as if I take that drug out of its packaging, open up the bottle, pour it onto a tray and start counting it out. Okay? And that just makes sense because you go from one level of containment to a lesser level of containment by manipulating the drug. Okay, so the common causes of absorption are, of course, through the skin. You inhale things. They're injected. You can get cut. You can get stuck with a needle. And the most common is, by the way, is ingestion. People tend to have residue on particular surfaces, work surfaces, and they'll have their skin exposed to that residue. And even though that it's absorbed through your skin, they'll also go and grab a ham sandwich and eat a ham sandwich, and it tends to be ingested one way or the other. Okay? So then there's also levels of exposure based on the activity of the drug itself, or the activity that you're performing on that drug. Okay? Whether we receive them, transport them, dispense them, compounding especially, and administration are probably going to be your top two levels of exposure because that breaks that drug all the way down to the bare entity and doesn't have any particular barriers of containment between you and the drug itself. So your potential for exposure is going to increase if the drug is outside of the syringe than inside the syringe, which, that kind of makes that's an obvious statement. But the other level of exposure that a lot of people don't think about is spills and how we need to take care of spills. This is a slide that's actually from USP 800 that kind of repeats what I just said, was talking about different things to think about whenever you're talking about receiving a drug. When you receive the drug, is it intact? Is it in a tote that's separate from other drugs? Is it in a plastic bag? Is the bottle that it's in, is it intact? Is there a crack? Is there a leak? Is the glass cracked or broken? We need to have things in our protocols that suggest what we can and can't do with those particular drugs based on how we receive them, how we transport them, how we dispense them, etc. The next level of containment talks about engineering controls. Okay, and engineering control is broken down into three different categories: primary engineering controls, secondary engineering controls, and supplemental engineering controls. Your primary engineering controls are your machines. Those are your hoods. Those are your containment boxes. Those are your glove boxes. Those are your negative pressured isolation compounding device that you're going to use if you use those for $7.95. Your secondary engineering controls is the room or the area that you put those machines in. Your anteroom, your sterile compounding room, your segregated compounding area. Okay? And then your supplemental engineering controls are your closed system transfer devices. Those are the things that we use whenever we compound chemotherapies or group 1s and hazardous drugs now, and whenever they're administered. There needs to be a certain level of closed system because that's the area where you have the most level of exposure to raw drug. Okay, so we're going to talk about engineering controls used for non-sterile hazardous drug compounding. 795 guidelines, okay? These are non-sterile products. Your primary engineering controls that you have to use for hazardous compounding has to be an externally vented or redundant HEPA filtered device. Has to be located in a segregated area. It has to be located in an area that meets certain criteria for it to be considered a hazardous area. An example of the devices would be, you could use your class 1 or 2 biological safety cabinets. You can use a compounding aseptic, contained aseptic compounding isolator, which are your glove boxes, but they're designed specifically for hazardous compounding. Your room requirements, your secondary engineering controls, the room itself has to be externally vented, has to have 12 air exchanges per hour. This is not an ISO classified area. This is not a sterile room. 12 air exchanges per hour does not give you any level of sterility. All it does is give you the negative pressure and externally vent. Okay? So, and it also has to be negative pressure according to 795 and 797 guidelines. Okay? The existing requirements also apply for non-sterile compounding. Notice that I put the existing requirements for non-sterile hazardous compounding include 795 and 797. The reason I included 797 on non-sterile hazardous compounding for the non-sterile products is because the devices that you're going to start using have surfaces that need to be deactivated, decontaminated, cleaned, and disinfected according to 797 protocols, because they have the same cleanable surfaces. Okay? You can't just clean them like you would your 795 compounding areas. Engineering controls for sterile hazardous drug compounding in situations where you have an ISO 7 buffer room. Okay, your ISO 7 buffer room is your sterile product rooms. Okay, those of you who have a chemo room, it's also your chemo room. Okay, this is not the anteroom area. This is talking about the device itself is in a sterile product room. All right, that room, or the device itself, has to be externally vented, has to be located in the ISO 7 buffer room, and you can use a biological safety cabinet, or you can use a controlled aseptic compounding isolator. Notice what it says here with a compounding aseptic compound, or controlled, the isolator, the CACI, has to be in a ISO 7 buffer room in order for you to compound sterile hazardous drugs in this particular setting. Okay, you can use your glove boxes in a negative pressure chemo room. You can compound sterile chemo, or your group 1s, or any other hazardous drug in that negative pressure room, and it be a sterile product, and it be different than if you didn't have that room to have the device in. And I'll talk about that here a little bit. It was hard for me to get that out, but I'll talk about that a little bit later on. The requirement for the ISO 7 buffer room has to be externally vented, has to maintain 30 air exchanges per hour in order for it to be considered ISO 7. Okay? Also negative pressure to the adjacent work area. So if you have an ante-room connected to your buffer room and it's a negative pressure buffer room, it has to be negative pressure to your ante-room. Some compounding facilities have a sterile product room that's directly adjacent to the negative pressure room. So it has to go from positive pressure to negative pressure. That chemo room still has to be negative pressure, the hazardous drug compounding area. Okay, so here we are trying to meet the 797 requirements also for sterility. So the surfaces don't change. The cleaning changes a little bit because now we're also talking about decontamination and deactivation, but the cleaning and sterility processes are the same in your chemo room as they would be in your sterile compounding room. Okay. The existing requirements also for engineering controls for hazardous drug sterile compounding in a containment, a compounding segregated area. Okay, this is not a sterile product room. You can compound sterile or hazardous products in a non-sterile room as long as you've got the primary engineering control, and as long as your primary engineering control is externally vented and it's located in this segregated compounding area, and it is either a biological safety cabinet or a compounding isolator, the glove boxes. Now, the reason I mention the glove boxes enough times is because there are some facilities that only have glove boxes. Here is a very, very important caveat to USP 800 and soon to be 797 as far as pairing up to USP 800. The room that you put that glove box in, if it is not a sterile product room, has to have external ventilation, has to have 12 air exchanges per hour, has to be negative pressure, okay? In order for you to compound those non-sterile products and eventually, or non-hazardous products. Eventually it's going to be even the non-hazardous sterile products have to be also there. But here's the thing, with this particular requirement, you're not meeting the sterile requirements for the room. You can walk into the room, you can use your compounding isolator. The difference is here. This is actually a chart that was produced by a manufacturer of the compounding hoods themselves. They know that this exists, and your state boards of pharmacy also know that this exists, and they know, and also your organizations that do your certification on the hoods and the rooms themselves know that this exists. One of the expected changes for USP 797, that's why it says proposed, is that even if you use the compounding isolator, the glove box, if you do not put that device in a 30 air exchanges per hour room that meets ISO 7 classification, every product that you make out of it has to be used within 12 hours. That includes 797. Okay, so that is your non-hazardous sterile products created in a glove box. That's going to be the expected 797 change that correlates to USP 800, because USP 800 will require that if you have a glove box and it's not in a sterile product room, you can only use every product that you make out of it within 12 hours. So your beyond use dates are going to change. So we'll talk about facility design. There's a lot of smaller hospitals that are having issues and struggling with some of the facility design. These slides are directly from the MedExcel group that they produced this PowerPoint presentation earlier this year with projected designs for some of the facilities of Ascension. I like to talk about this one. It starts off in the very center of this particular slide. The room itself is labeled as a non-hazardous and hazardous sterile compounding room. One of the first things that people would do is they'd raise an eyebrow on that and say, why would you ever compound a non-hazardous and a hazardous sterile product in the same room? That particular design is for those facilities that predominantly produce chemotherapy. These are for your infusion centers, your cancer treatment centers and stuff, to where 98% of everything that you produce is going to be a group 1 hazardous drug. And the other 2% is going to be your pre-drugs, like your Zofrans, if you have to make a Zofran IV, or your Phenergans if you need to make that, or something that's not necessarily considered on the Niosh list at all. You can make those drugs in a chemo room, and I keep using that word chemo because I know that people kind of relate to that, but you can make those drugs in a hazardous product room, but you have to treat them like a group 1 drug. You have to label them as hazardous, and you have to bag them as hazardous, and you have to administer them as hazardous. You have to treat them just as much as a chemotherapy or as a group 1 drug as the group 1 drugs that you're compounding, which really isn't a big deal if 2% of what you make falls into that category anyway. But they took that particular design and moved it into the other two that are on either side of the slide, but they didn't change the labeling. So in the bigger areas, you've got a sterile IV preparation room, which those are your non-hazardous IV preparations. The one that says non-hazardous and hazardous sterile compounding, that's just your hazardous sterile compounding room. Those are your negative pressured group 1 drugs. Notice that there's some flaws with some of the design, but that's not like it's something that you can't make up for with appropriate standards of practice associated with these particular areas. One thing that I would like to get across is that whatever you do not have in your facility build, you're definitely going to want to try to make up for with standards of practice, operating procedures. This is talking about dedicated hazardous compounding again. There are some of the designs for some of the smaller facilities that they're probably going to have to make a decision as to whether they need to have Group 1 drugs compounded in their facility or not, and if they do, then they're definitely going to have the standards of operating procedures, your operating practices have to correlate to that in order to meet the requirements of compounding those particular drugs. Let's talk about some supplemental engineering controls. Closed system transfer devices. These are actually manufactured products that are designed to fit onto Luer lock syringes to make it to where you cannot manipulate anything that's inside the syringe. It closes the system out altogether without actually activating the device on the tip of the syringe. Also, probably there's some that are spring loaded. There are some that are like membrane loaded devices, but these are designed to prevent any spillage or accidental exposure from a syringe or from an IV line or from any other type of port that when you create these type 1, these group 1 products. USP 800 currently has a recommendation for closed system transfer devices. They say that USP 800 says that they should be used when compounding hazardous drugs when the dosage form allows. So as far as the pharmacy activity is concerned, it's a recommendation from USP 800. It's still a requirement from USP 800 that they're used during the administration of the drug. Ascension, however, requires that even during the compounding that we use we use the closed system transfer devices. So for those facilities that don't currently have those closed system transfer devices, my recommendation would be that you need to get in contact with the proper drug representative and make sure that you have some of those devices on board. Ascension also has strongly urged us to use the Chemo lock and the Chemoclave systems. Those, I believe, you can look them up according to name, like Chemo lock or Chemoclave, and some of the products will show up in McKesson. So whenever you go under McKesson and you start looking some of these devices up, you definitely need to get some of these on board and start utilizing those. Talk about personal protection equipment. This is also a containment mechanism. So when we talk about personal protective equipment, we're obviously going to talk about gloves, gowns, masks, eye protection, full garbs, hazmat suits, whatever you want to call them. As far as whenever we talk about hazardous drugs, that's one of the first things people have in their images is I'm going to walk into a room looking like Darth Vader and sounding like Darth Vader because I've got this helmet on. It can go that high if there's a level of exposure that justifies that, but mostly what we're talking about are the gloves, the gown, head, hair, shoe, and sleeve covers, eye and face protection, respiratory protection, and then how we need to dispose of those products. Again, that's something that's not necessarily in the build itself. That's something that we'll have to have standard operating procedures to take care of, is how do we dispose of these products once we put them on. So we're going to talk about gloves. They need to have the standards need to be met as far as ASTM is concerned. They need to be powder-free, intact. There are situations where you wear a single pair and there's situations where you wear a double pair. Do they need to be sterile or non-sterile? Okay, is what you're doing, does it require a sterile glove or does it not require a sterile glove? I know that, for instance, if you're in a sterile compounding area, then they need to be sterile. And you need to have the same procedures and protocols that deal with the non-hazardous IV preparation of, making sure that you have a mechanism by which you keep them as aseptic as possible through sanitation. Okay, talk about the gown. This is not your isolation gown, and the reason I say that is because please don't allow the nurses to think that an isolation gown is going to protect them against any type of chemotherapy spill. These guidelines don't affect just pharmacy. They're for the entire hospital system. So for those of us who are trying to come up with protocols and procedures, we need to consider that there may need to be some purchases on the nursing side of permeability tested gowns, that they're resistant to absorption, that the gown closes in the back and not the front. There should never be a seam in the front of a chemo gown. And when inappropriate substitutions are used. Not only in the administration sites, like for instance, if your hospital has an area where you administer antineoplastic drugs on a nursing floor, also consider the fact that there's antineoplastics that are administered in the OR or in a cath lab. And those particular settings must also have the same system by which you protect yourself with personal protection equipment. Okay? Head and hair and shoe covers and sleeve covers, I have yet to find anything that makes that suggests that there's any difference in the products as far as protecting your hair and your face. Now there may come up later on. There may be some products that are considered. This is actually considered a chemotherapy or a level whatever bouffant hair cap. But currently the ones that we have aren't permeability tested. They aren't resistant to fluids. The same thing goes with the booties. So there have been situations in which chemotherapy, antineoplastics have been absorbed through 2 layers of booties and actually been taken home on someone's shoes. So that risk exposure changes and should change whenever these requirements come out. Talk about eye and face protection. Your minimum requirements in a pharmacy is, according to USP 800, is goggles. My recommendation would be that you might want to consider what you're doing to where you would wear maybe the goggles and a face mask, or a combination of a face mask with not only the respirator side of it all, but the face protection too. Some of the things in the USP 800 suggest that even the full face respirator with the mask itself doesn't provide you adequate side splash protection, that you need to have goggles on anyway. Talking about the respirators, you need to have N95 masks. The N95 masks have to be fit tested. For those pharmacies who currently don't have N95 masks that are fit tested, you need to get there. Because that's going to be part of the protocol, and you need to get nursing involved with being able to fit everyone in the pharmacy with an N95 mask, because if whatever we're doing to this drug causes us to put on respiratory protection, it's most likely going to be the N95 mask. Okay? A surgical mask is inappropriate. Surgical masks are not resistant to droplets or aerosols. Okay? You can still inhale certain types of aerosols. So any type of surgeon or any type of OR nurse that decides that they're going to just wear a regular surgical mask during a chemotherapy or a antineoplastic administration, that's not appropriate personal protection equipment. Talking about disposal, all disposal for personal protection equipment used during any activity with a hazardous drug should be considered contaminated. So it needs to undergo whatever your containment processes are for discarding contaminated materials. One caveat for the nursing side of it all is Joint Commission has actually suggested that any waste product, any human waste product up to 48 hours post-administration of an antineoplastic drug is considered contaminated. That's sweat, urine, feces, anything that stuff comes in contact with needs to be considered contaminated. How do you treat that differently? You cannot rewash and reuse contaminated linens. You can't take any of these clothes home. They're considered contaminated. So then there needs to be some protocols on the nursing side of it all to deal with those. We'll talk a little bit about some of the standards of practice that are coming up. I'm just going to go through this real quick. The number one is going to be the hazard communication program. For anybody that's working on USP 800 in their pharmacy, please don't consider this just to be a pharmacy function. Get as many different types of people from as many different types of professions as you possibly can to have regular scheduled meetings talking about how we're going to handle and contain these products in our facilities. That's your hazard communication program. Your Niosh list and your containment strategies that are put in your assessment of risk will be disseminated to the nursing side of it all, will be disseminated to the environmental services side of it all. So whenever you come up with whatever plan or program that you're going to have as far as those assessments of risk are concerned, please make sure that it's in a format that is communicable to those other professions, because they're going to have to know about it. That's the only way that they know what to put on. Labeling hazardous drugs, some of this has to do with not only do we have like certain, hazardous drug labels that are going to be like attention grabbers, but if you've got a computer system that allows you to label this drug as a group 1, group 2, or group 3, whenever you dispense that product, on the label itself, it says group 1 Niosh. So that should alert a nurse to go, okay, well, I need to look this drug up and see what I need to wear in order to administer this drug. How do we procure hazardous drugs? Our wholesalers, ironically, are not required to follow USP 800 guidelines currently. I'm assuming that there's going to be enough public feedback on that to the point where even our wholesalers will have to start having some sort of containment devices for their hazardous drugs. The Ascension recommendation on this was to order all of your hazardous drugs separately. That way you've got them in different totes. Make sure that your use of engineering controls is spread out all the way through the entire facility, that if there's ever any situation for some of the smaller hospitals that aren't open 24 hours a day where someone else has to compound a drug, there needs to be either a facility build to it where there's a negative pressure room, or there needs to be some standards of operating procedures that deal with other practices other than pharmacy in order to compound those products adequately. And obviously, use of personal protection equipment, that has to be spread throughout the entire hospital. Everybody needs to be aware of these drugs and what to wear. DD&C&D, that's deactivation, decontamination, cleaning, and disinfection. There needs to be that extra caveat on when you're cleaning up hazardous drugs. The deactivation, decontamination, and the cleaning and the disinfection needs to be done in order. It needs to be deactivated, decontaminated, then it needs to be cleaned, then disinfected. The disinfection of choice is still isopropyl alcohol 70%. The deactivator and decontaminator can be Paradox, which is what we use currently in our sterile product side of it all. But it can be Paradox, but it must be used more than twice. Okay? Clean it once, clean it again, clean it the third time, then disinfect. Transport deals mainly with transporting hazardous drugs from facility to facility. Those situations, you have to make sure that whenever you do that, if you ever do that, that the person that is transporting the drug is aware that the drug is considered hazardous and has some sort of protection, containment, and understands the protocols. Environmental monitoring is important on the nursing side, and this is what everyone that has ever had any dealings with a chemo protocol, this is where when your exposure levels say, I need to start drawing blood on you, and I need to make sure that you're not getting any of this absorbed. That's your environmental monitoring, number one. Number two is this is requiring pharmacy to actually be responsible for swabbing areas that handle hazardous drugs. That's throughout the entire facility. Okay, not just the pharmacy where we do the compounding, anywhere they administer the drugs, anywhere they've transported the drugs, any surface that we consider that might be contaminated, we need to monitor that with swabs. Unfortunately, Ascension has not decided to mandate what type of swabs we use, but we need to do this twice a year, and it needs to be done on surfaces that we consider might be levels of exposure even outside the pharmacy. Spill control, the reason I put this down as last is because this is something that needs to be its own entity. You've got three types of spills. You've got the spill that you can contain yourself, and a couple drops here or there, and you just need to know what the drug is and how to take care of it that way. Then you've got the spill that's big enough that you need to have a spill kit involved in. And it's small enough that a spill kit can contain it, not more than one, but just one. And then you've got those spills that need to have a specialized team to come in and make sure that it gets cleaned up, deactivated, decontaminated, that there's a report of how many people were possibly exposed, that way that you can do your level, your post-exposure protocols for that. So your spill control needs to be addressed later on, and it needs to be addressed at a level that's beyond just this particular presentation. Medical surveillance, again, that's whenever you get your nursing, your employee health nurse behind it all, and they start drawing labs on people who have multiple levels of exposure to the drugs. When we handle the drugs, let's just make sure that when handling the drugs isn't just in the pharmacy, that it's everywhere, that there's different places that we transport these things, that there's different places that we administer these medications in, there's different places that can have spills. For those smaller facilities, there's different places that we even compound these particular products, and we need to make sure that we have, if we don't have a facility build that controls those things, we need to make sure that we've got standards of operating procedure that do that. So your standards of practice are going to deal with all of these, occupational safety, your medical surveillance, but definitely your hazard communication program. Everything that we're working on right now needs to be in a format, in a manner of communication that it's at a level that everybody understands it and knows what to do with it. So let's not just consider this just to be a pharmacy function. This is a hospital function. And that's all I've got for today. I'll leave you with a parting thought of one of my favorite Gary Larson Far Side jokes. It talks about her answer was off by miles. Sheila's cow sense was always a target of ridicule. Some of these things we just need to have horse sense with. Some of these things are pretty straightforward and they make sense. Other things kind of get into the situations of, but what if this happens, what if that happens? Those are going to be those situations where you need to run it through a process and come up with standards of practice. I do have, how much time do I have? Any? Okay, I want to take this time to go over the questions that I have created for this particular presentation. These are actually the answers to the test questions, and I don't mind giving you the answers to the test questions because we're going to talk about these as if they were talking points. Again, USP 800 is a federal document that was created by experts from multiple federal panels, including the USP, the FDA, Oncology Nursing Society, and Niosh, which is now part of the CDC. So it's good, and its official date is actually December 1st of 2019. Yeah, I wish I had bingo chips out here so where people get these right, they go, I got this one right. When we talk about an entity's list of hazardous drugs, each entity, the facility itself, has to maintain their level of their hazardous drugs and review it annually and whenever a new agent or dosage form is used. So this is something that it doesn't stop with just the list. It's a progressing movement of adding stuff and subtracting stuff. And again, your operating procedures behind it, your policy and procedures should be something having to do with an addition or an addendum, an amendment to your current policies of adding and subtracting things to your formulary to include the hazardous drug identification and protocols behind that. Talking about which statement describes strategies for meeting the USP 800 containment requirements. This one was kind of tricky, but what I was talking about is there is a distinct separation between your Group 1 antineoplastic drugs and active pharmaceutical ingredients that are required by USP 800 to meet all of your containment strategies in order to reduce those levels of exposures. And then it separates those non-antineoplastic, non-Group 1, non-active pharmaceutical ingredient products that says that you should be able to do an assessment of risk to determine what containment strategies are best for your facility and more appropriate for your facility. When we talk about pharmacy construction to USP Chapter 800, everybody, there's been some reaction of well, because of these new rules and regulations and guidelines, I'm going to have me a new pharmacy. Here we talk about compounding. A pharmacy actually can compound both sterile hazardous drugs and sterile non-hazardous drugs in the same buffer room. That was that situation in which you are basically a provider of cancer treatment. And you can make the non-hazardous sterile products in the same room, but you have to treat them as if they were the hazardous products. They have to be labeled as such and handled the same way. Let me see if there's a quick way to do this. All right, talking about 797 harmony with USP Chapter 800. Notice that it talks about hazardous drug compounding being performed in a separate area designed for hazardous drug compounding, but it also suggests that low and medium risk hazardous drug compounding sterile products may be prepared either in a biological safety cabinet or a compounding isolator located in a negative pressure room with 12 air exchanges per hour. That can happen, but when it does happen and you're not in that ISO 7 area and you don't have that primary engineering control in that secondary engineering control the way it's supposed to be, according to the 800, and the expected proposed changes to 797 suggest that if that situation happens and you're not in that sterile compounding room, then your compounded product is only sterile for 12 hours. Okay? We're talking about the difference between the rooms in meeting USP 800 requirements for compounding sterile products. Notice it says that a hazardous drug sterile compounding area has to provide that ISO class 5, which your hoods do that. That's pretty much the function of all your hoods, all your primary engineering controls, unless you're talking specifically about 797 containment issues. Those that are designed for sterile products give you the ISO 5 classified air. And within an ISO 7, this talks about if it's in the ISO 7, you can actually produce a longer than 12-hour beyond use date. If it's not in the ISO 7, it's considered, if it's in only the 12 air exchanges, it has to be less than 12 hours. Which of the following USP Chapter 800 recommendations are considered essential requirements? The recommendation that we have to use a closed system transfer device in order to compound sterile product hazardous drugs. Okay? The administration side of it all is a requirement by USP 800 for nurses to have to use those closed system transfer devices. So I think that it just makes sense for us to be able to compound them using the same device system as whenever we administer them. The other part of it is that we have to have environmental wipe sampling. That's actually a suggestion from USP 800 because there's really no standardization there. But Ascension is mandating that we do that. And I think that that's really a good idea also from a data collection standpoint, that we can actually have hard data that proves certain areas are more disposed to increased levels of exposure than others. What effect do the Niosh criteria for defining hazardous drugs have on chemotherapy cultures? Now remember that this chemotherapy culture is basically the thought process that hazardous drugs are chemotherapy. And that's really not true anymore, that it's been expanded. Niosh expands that definition of hazardous drugs beyond antineoplastic agents to include any agent that exhibits or has those the capabilities of carcinogenity and those other characteristics that are defined by Niosh. Niosh doesn't define chemotherapy, and it doesn't use the word chemotherapy at all. I would like for that particular thought process to end for those pharmacists that go, well, I don't compound chemotherapy, so I don't deal with hazardous drugs. That's not a true statement, because the hazardous drugs has been expanded beyond your antineoplastics. When considering the USP Chapter 800 defined levels of exposure, what two factors cause an escalation of the potential exposure to the hazardous drugs? It's the drug itself, okay? The characteristics of the drug itself. What causes that drug to be absorbed more readily? Does it form an aerosol? Is it a powder versus a tablet? Is it a chalky tablet versus an enteric coated tablet? Is it a capsule? That type of thing. Is it a liquid that's in a bulk package versus a unit dose package? So the drug itself has those characteristics, and then what you're going to do with it has the potential to increase your levels of exposure. An injectable Niosh Group 3 hazardous drug was spilled onto a nurse prior to administration of the dose to the patient. What is the most appropriate course of action? Notice that this is a Group 3 drug. It's still considered a hazardous drug by your facility, okay? So there really aren't any guidelines that say this needs to be cleaned up as a chemotherapy or as a level 1 hazardous exposure and everything. But you do have to have policies established by your facility that suggest how to clean those types of spills up. You can't just wipe it up because it's still considered a hazardous drug. And that's all I have. I'm going to open the floor to questions. Feel free to ask me questions. I hope that I can answer them appropriately. And my hope is that I brought to your attention that we need to have a certain level of things done in order to progress with this USP 800 protocol, in order to be compliant with USP 800, especially by the enforceable dates. I will tell you that any well-planned program is going to address not only USP 800 but also the regulatory agency requirements, your state boards of pharmacy and your joint commission requirements that are going to come down the pipeline along with all of this USP 800 stuff. So, are there any questions from any of the live streams? Would I know? Okay.
I do have one question.
Yes, sir.
They email you.
Yeah.
I found it interesting that the Niosh list is updated every 2 years,
Mm-hmm.
but they make us update it every year. Do you think that that may change eventually to whether they're doing it annually or that we would go to a biannual?
Okay, the question was that the pharmacist notes that Niosh itself updates its list every 2 years, but we're required to update our list every year, and wanted to know if there's going to be any type of reaction as far as increasing the frequency of the Niosh list itself or decreasing the frequency to our requirements to 2 years to kind of match that. My response to that is more than likely no, because we need to keep a higher level of control over what we carry and dispense and use in our system, number one. And number two, the way that the Niosh list and USP 800 updates happen is they propose the updates and then they have feedback from from facilities in order for them for their updates, their next update, to be the most robust information that you can possibly have, and that process tends to take a little bit longer than every year. So, but that's a really good question. The thing to do though is with your policies and with your protocols to make sure that you add that into your formulary addition and subtraction, that you use the same criteria that Niosh is going to use anyway. When you have a new entity that's after the latest version of Niosh and it's not on that list, run it through the whole protocol and determine its level. More than likely Niosh is going to do the same thing.
Those double chemo gloves, does that mean you're putting two on, or is it just a thicker?
The question was for donning chemotherapy gloves. Whenever it talks about double chemo gloves, is it double? Is it 2 pairs of chemo gloves, or is it 1 pair of thicker chemo gloves? It is 2 pairs of chemo gloves. There are situations that especially with the compounding procedures, that's going to require that you perform an activity being double gloved, and then during your degarbing processes, you're going to take that outer layer of glove off, and in order to move from that sterile product room into a different room. So, and you don't want to go all the way to bare skin while you're still into that negative compounding area. Anything else? Yes, sir.
Brad, talk a little bit about non-sterile hazardous compounding and sterile hazardous compounding, if those can be combined and done in the same area.
Okay.
As, for example, a non-hazardous, hazardous non-sterile, could it be done in the chemo compounding?
Okay, the question is, and make sure that I got this right. The question is, can non-sterile hazardous compounding and sterile hazardous compounding be performed in the same room?
Correct.
The answer to that question is yes. And you're going to want to make sure that it is a room that is adequate to make the sterile compounding hazardous product. So you can compound non-sterile products in a sterile compounding hazardous drug room. And you can use the exact same hood. Okay? You can do that. The caveat behind that is if you do that, whenever you compound something that is non-sterile in that sterile compounding hood, you have to run it through the deactivation, decontamination, cleaning, and disinfection process in order for you to compound anything sterile after that. So if you use those hoods, you can use those hoods to compound non-sterile products, but you have to clean them. You have to do the deactivation, and that not only includes the hood, but anything that you use as a device has to run through, it has to be cleanable, number one, and you have to make sure that it runs through that cleaning process in order for you to pull it out of the hood and contain it in some sort of level in order for it to be stored in its proper areas. But once you've used that hood, it has to be cleaned properly and adequately before you do any type of sterile compounding on it. Anything else? Thank you for the opportunity to talk to you guys. I hope that what I've presented is something that's going to be useful not only to you guys here, but also to the ones that are on live stream. If there's ever any questions, feel free to contact me through email. I'll be more than happy to answer any questions to the best of my abilities. And this is something that I'm hoping that we can get up to par and progress forward and keep moving on. Appreciate it.
Excellent job.
Thank you.
I almost fell asleep once. It was pretty good.
You had one sentence in there for Alex. It's recommended that you order your hazardous materials separate from your non-hazardous, so they come in.
Yep.
So he was waiting on that one.
Also in the receiving side of it all.
To guard up to receive something.
The other,
We don't even have a room yet, the receiving room.
Hey, one thing that I wanted to ask, again, they're on the table, is essentially committed to any financial support for any of these recommendations. Let's get that on tape.
was there a question?
Let me see. Maybe no.
It's a little late now.
I know, but it won't be recorded, but I just
Thank you,
want
sir.
to still here if you did.
100% smiley face.
Look what you, look, I couldn't get the, look at the last page. I told Alex, I said, I don't know what the answer is. We didn't realize this was a choice, and I'm going, I've got a mark there, and I'm going, I don't know what the answer is.
I know, right? That's funny.
Yeah, I didn't have that one.
Yeah, well, I'm glad that that's a caveat that I had no control over. Thank you, sir. I appreciate it. Hopefully I stayed in frame, right?
You're good.